Thank you all for having me. I'm excited to think about how we can expand aphasia access outside of the aphasia world, which seems kind of like an oxymoron, but I think it'll lead to some exciting conversations. Here we go. Perfect. All right. Can everyone see my slides? Great. So I just wanted an opportunity to kind of set the framework for what my research has been for the past 5 to 10 years, and thinking about how we can expand our thinking of aphasia access to apply to other clinical populations. I was clinically trained as a speech language pathologist and worked at Voices of Hope with Jackie Hinckley. So a lot of my conceptualization of how we design treatments is really based on the life participation approach for aphasia, but how we can apply that for older adults who are at risk for dementia due to Alzheimer's disease. So to get started, I just wanted to briefly acknowledge the team that I work with, and this research is funded by the NIH. I currently have a K23 and an R01 supplement as well. And I really wanted to present this or start with talking about the team that I work with, because it's a lot of academic clinicians. And I think our work is really focused, as aphasia access is, on the patient first, and how can we improve their life participation, and then how do we develop rigorous science to support our treatment designs and assessment tools that we use to enhance their life participation as well. So I work quite closely with Matt Cohen, who's a neuropsychologist. I also work on a team with geriatric psychiatrists, engineers, and kinesiologists as well. So we really try to come at it from this multidiscipline and multi-component approach as well. So to really get our conversation going, I wanted to set the framework of why I am particularly interested in working with older adults who are at risk for dementia due to Alzheimer's disease. So as many of you know, the baby boomer generation is about to progress through the age band for which they are at greatest risk for dementia. So in 2020 alone, there are about 5.8 million Americans who experience Alzheimer's disease, and that number is expected to triple in the next 30 years. It's estimated that it's going to affect approximately 15 million United States residents. So this is a massive burden on our public healthcare system. And why this is quite a burden on our public healthcare system is because of the costs. And it's costing our nation approximately $1.1 trillion by 2050. And this is a huge issue because of the current state of the practice. And there's really a lack of compelling pharmacological interventions that prevent or slow down the progression of Alzheimer's disease. Even with the 2 new clinical trials, the evidence, the effect size is quite small. We're still waiting for Medicare to kind of approve these treatments because there's really a lack of compelling pharmacological interventions and effect sizes. So that really places us with a big need. And when we think about that need, it's really for behavioral treatments that focus on early diagnosis, managing symptoms, and addressing modifiable risk factors so that we can help these individuals maintain their independence for as long as possible. And I think that idea of maintaining independence is where I always put my LPAA hat on, of how can we make sure that they're living at home, maintaining their functions and their skills in everyday life. And this is especially important for this population because recent evidence suggests that there's about 12 modifiable risk factors that are responsible for approximately 40% of dementia cases worldwide. So this creates a massive opportunity for healthcare professionals. So if we can treat those risk factors, if we can modify those risk factors, then we may have an opportunity to preserve or maintain independence. So when we think about these behavioral treatments that really focus on modifiable risk factors and managing symptoms, we want to think about, well, where would this occur? In Alzheimer's disease, right? We understand it as this continuum and this progression. So ideally, when would these interventions take place? And We're thinking specifically about Alzheimer's disease in particular as the medical cause, but I want to separate and distinct between the clinical syndromes and this medical cause. So when we think about the clinical syndromes, we can think about kind of two distinct pots here. We have mild neurocognitive disorder and major neurocognitive disorder. And these clinical syndromes are characterized by impairments in cognitive domains, such as memory, attention, and executive function. And these impairments at these cognitive domain levels have immediate consequences. And this is when we can kind of think of the application of these cognitive skills, right? So if somebody has impaired memory or attention, then they're going to have challenges with reading or writing and social communication. Or for my OT colleagues, complex motor planning, safety awareness, and planning transfers. And when we think about the key distinction between the mild neurocognitive disorder and the major neurocognitive disorder, it's one's loss of independence, and that both individuals with mild and major neurocognitive disorder, we define both of those syndromes as impairments in cognitive substrate, but the key distinction is one's ability to complete activities of daily living independently. So that's why we really want to focus on mild neurocognitive disorder, why their independence is still relatively intact. So we really want to think about, well, then what behavioral interventions can we introduce early on prior to the onset of dementia due to Alzheimer's disease? And in this pursuit, small effects are highly significant. It's estimated that by delaying the transition of dementia by only a single year could reduce the number of individuals living with dementia by 11.8 million globally. So we're talking about a huge public health impact by only delaying the onset by 1 year. To kind of give more context, in my research, the treatments that I try to design tries to delay the onset by only 1 month. And even 1 month would reduce the cost on our public health system by a tremendous amount. So, okay, hopefully there's buy-in now that we want to provide treatment at this stage before the onset of dementia due to Alzheimer's disease. So when we think about that, we need to consider then, well, what treatments preserve or improve cognitive skills and independence? And that's really cognitive training and rehabilitation. And I think SLPs are uniquely poised to provide cognitive treatment and rehab. And that's why I'm particularly interested in this for Alzheimer's disease care as well. I think we are a beyond underutilized workforce in this space. And I also think that we often think of cognitive training and rehab as synonymous with traumatic brain injury. And hopefully with a few facts that I'm going to show you in a second, we can think about why we can't think of it as synonymous in that way. So my work and my research is really focused on cog rehab with this population. And when we think about cognitive rehab, and this isn't actually that different of how we think about language rehab in a lot of ways, we can kind of think of it as much as kind of seems crazy to think about because we never think about anything as black and white in the SLP world, but somewhat as black and white of kind of what are the two approaches of cognitive rehab. Well, first, there's restorative cognitive treatment, right? So that's when we try to repair the cognitive substrates that are impaired through repetition of tasks, right? So the active trial is a really great example of we're going to train drill-based approaches to really improve one's memory, attentioning, or executive functioning. And what those trials have shown that it does improve at the impairment level, but it doesn't generalize, right? And that's what we're saying in the language in the rehab world a lot as well. We're doing drill-based approaches on language skills, but is it generalizing? Is it making a difference when they're talking to their doctor or when they're communicating with their grandchild over the phone? And we're having these same conversations in the Alzheimer's disease research world as well. So the alternative approach, and once again, I acknowledge that it's not black and white, but I think it's helpful to think of it in this way, is compensatory rehab. And that's when we train strategies to help one increase their ability to complete their activities of daily living. So we're kind of bypassing that impaired area by allowing them to use a strategy to compensate for those impairments in their everyday life. So the goal of these interventions is not necessarily to fix the impairment, but to delay the transition, right, to delay the impact on daily functioning. So when I try to teach and think about compensatory cog rehab, we're really focusing on the bottom half of this model, where I think restorative treatment is really focusing on the top half of this model in a lot of ways. And especially the conceptual difference of the population that I'm talking about versus aphasia is we also need to consider the progressive decline in these folks as well. So what treatment then do we have available in providing compensatory cog rehab to individuals with mild neurocognitive disorder? Well, the best treatment approach out there right now is the memory support system. And this is a notebook calendar system. It is a paper version that has 2 pages per day. It looks like this. And it asks patients to record their appointments, their to-do items, and their journal. It's 12 sessions, 1-hour training sessions with both the participant and the study partner. And this is really adapted off of the cog rehab dynamic duo of Solberg and Mateer's 3-stage approach with the acquisition, application, and adaptation, really common in the traumatic brain injury literature as well. So this modified that approach specifically for individuals with mild neurocognitive disorder. But the challenges with this approach is that it does provide some initial evidence for generalization and maintenance over time and preservation of functional performance. However, there's a lack of scientifically rigorous research designs for mild cognitive impairment. This approach that I just showed you is part of this really big multi-component habit program, and it often now is kind of lumped into a lot of other multi-component interventions, and we don't have really strong evidence for the use of it on its own. And when we think about speech pathologists, well, we're often providing these treatments in isolation and not in this multifactorial component. The other big part of it, and those who are clinicians in the room, I think this will resonate with, is it's one size fits all. And so it's a lack of person-centeredness. If you just go to this image, if you just go to this image here, I'm sure some of you are already thinking, ooh, I wouldn't like the lines that close, or I wouldn't want to see it on all one page, or, oh, I couldn't do it paper, I would have to do it electronically, right? We all have different preferences and needs, and those preferences definitely impact our adherence to what we learn in treatment. So it's a large amount of the work I do is to try to make our treatments standardized and structured, but also person-centered. And then the other big component is many of these cog rehab approaches for individuals with mild cognitive impairment are underspecified and difficult for clinicians to adapt and use in clinical settings. They're designed to use in research settings, which is really challenging. And that's a huge problem because these patients are being seen in clinical settings. And in particular, speech language pathologists are providing a large amount of CogCom care. It's accounting for about 28.5% of the adult services that they provide, according to a 2017 survey. And when we break up CogCom even further, dementia accounts for twice as many as traumatic brain injury, right? But when we think about the cog rehab that we have and what we're taught in school, it's often specifically for traumatic brain injury. And that's great, and it's a wonderful, however, we need to conceptualize it and think about it differently when we're dealing with geriatric neurodegenerative conditions versus traumatic brain injury. It's a different way of thinking about it. So then what does that leave us with? It leaves us with somewhat of an undereducated workforce that's seeing a large amount of clients that they may not necessarily have treatments for that they can use, or they may not have sufficient training in as well. So although clients with dementia are amongst the largest consumers of behavioral treatments of speech language pathologists, there's limited to no evidence or theoretical base to drive the care that we provide these patients, especially before the onset of dementia. And that really leads to a poor delivery of clinical services, which is a huge issue. So my entire line of work thus far has been really designed to enhance the evidence-based practice that we have for SLPs to be more confident, to be more competent, and to have skills and treatments and techniques that they can use because these individuals are such a large consumer of care. So I just kind of want to wrap up here by just showing or describing a little bit of the treatment approach that I have done some research on, and that is currently the focus of my K23 that I'm running a clinical trial with right now, and then describe briefly an assessment tool that I also designed for this population that I think could be really applicable to people with aphasia as well. So the treatment that is the focus of most of my work is called the structured external memory aid treatment, which actually started out of my master's thesis with Sarah Wallace, so kudos to her as well. But what this treatment has evolved quite a bit since my master's thesis, but really the core here are the active ingredients of the structured external memory aid treatment. So it's designed in a group format. It's to be delivered in a group format. And I really saw the value of the group format in my LPAA clinical training. And that was kind of a huge component, that to have that group component, that psychosocial support. It's designed to be 6 weeks. Many of these other treatments for this population are extremely intensive and designed over a long period of time. I wanted it to be in a time frame that was able to be implemented into clinical practice settings. So it's about 6 weeks. We focus on training specific external memory aids to support one's ability to complete activities of daily living. All the strategies that we trained are directly connected to one's activities of daily living. We train multiple types of external memory aids because of the person-centered preferences. So each week there's a category that's trained. So for example, we train calendars, and within calendars, we talk about paper calendars, electronic calendars, monthly calendars, daily calendars. And the idea that is that there's a structure to the framework of the session and how it should go. However, the content or the aids that are used are specific to the individual, right? Like Will may use a Google Calendar to remember his running schedule, and I may use a paper calendar to remember when I need to pick up my child from dance practice, right? We have different needs. However, it's still use of the calendar. We train it using that 3-step approach that Solberg and Mateer have tested in a number of different formats. And the goal is that you're using these strategies a part of your daily routine to make a habit and use of them. And then, like I said, we train multiple different types. And some of the categories we go over are timers and alarms, note-taking systems, personal information, calendar as well. And the focus of my line of research is really to follow the NIH stage model for development of behavioral interventions. So right now, I have a clinical trial to test it in research settings, so randomized controlled trials to look at the efficacy of the intervention in research settings. However, the next goals are then to look at the real world efficacy and the clinical effectiveness as well. So thinking from the start, how do we actually implement this in clinical settings? So that's kind of where my research is going to follow, to provide kind of these standardized treatments that are actually clinically deliverable. And couldn't give a shameless plug here, but we are, of course, recruiting always older adults, 60 plus, who have some concerns about their memory. And we do some comprehensive 2-hour Zoom testing. We're recruiting all over the country. And then based on their cognitive status, they then can be enrolled in a number of our clinical trials. The structured external memory aid treatment trial is just one example of some of the work that we have going on at the university. Then the last piece that I just want to end with is the assessment tool, because I think this is really applicable to the aphasia access world. And I feel like every time I go to aphasia access, the conversation is always, well, what are the outcome tools that we're going to use, or how do I make this more person-centered? And I felt that way when designing the CMAT, right? I was thinking about, well, what data do I need for treatment planning? I can use performance-based measures to examine their strengths and weaknesses, right? There's really strong neuropsych and SLP measures that I can use to determine their strengths and weaknesses. But I didn't really have a standardized and structured way to determine what my patient's goals were, what their everyday memory was like, and more importantly, what their compensatory strategy use was and their preferences, right? Most people use calendars already. And too often do we find out session 3, session 4, oh, they already have a calendar system in place, or, oh, they actually hate technology, right? We're finding out these things way too late. So how can I capture this information early on to help me better design my treatment? So that's why I have been working with a team of folks on designing the functional external memory aid tool, or the FEMAT. And the purpose of the FEMAT is not to diagnose, but to support treatment planning. And you can request it for free. And we have a whole website now kind of designing how to use it. But to get us kind of starting thinking about how we could use this in the aphasia world as well, I just wanted to provide some brief information about it. It's a 15-minute performance-based tool. And how it's different is that I place items on the table in front of everybody. So it's compensatory strategy. So there's a timer, there's calendars, there's notepads, there's pen and paper. And I let them know we're going to role play through some everyday task. There's all of these things in front of you. I label them and I say, you can use any of these things to help you complete these tasks. I want you to show me what you would do in everyday life. You can also use anything with you as well. For example, like their phone. And what I actually want to measure is not necessarily were they able to complete the task, but how they actually completed the task. So you'll see an item is, you just received this invitation for an upcoming party. Show me how you would remember the information for the upcoming party. I want to see how would they actually remember that information. And then I score them based on their use of an actual strategy. Did they explain that they would use a strategy? Did they attempt to use the strategy? Did they accurately use the strategy and document all of the correct information? I want to see how they use these types of strategies, so then I can better design my compensatory treatment plan based on their use of compensatory techniques. And we just came up with version 2.0, which has a nice facelift and a nice manual with it as well. So this manuscript just came out in AJSLP. And like I said, it's connected to a website that goes into much more extensive videos of how to do this and how to use this tool as well. But what I wanted to kind of leave our discussion on is thinking about tools like the FEMAT and how could we use tools like the FEMAT or use the concept or the framework of the FEMAT to examine multimodal communication support. So when I was an aphasia clinician a bit ago, I would get very mad because I would give these assessments to folks, right? And they would use their phone, right, to do text to speech, or they would write down the answer. They would ask me to write it down. And I wanted to give them credit because that's the information that actually helped me better design my treatment plans. And there are some tools like that, but the FEMAT really kind of makes me think about, could this idea of using an assessment for treatment planning also be useful for better understanding the multimodal communication support one may be already using prior to treatment? I think it's also helpful for us to think about what tools are available in the aphasia world to help us with goal development. Is there kind of this structured but personalized tool and framework? And then really, I was hoping that this conversation just sparked some excitement leading into the Leadership Summit of how can we expand aphasia access to include life participation focused treatments with other clinical populations beyond people with aphasia from stroke.